ماشي. بسم الله
هنبتدي
الرحمن الرحيم.
السيمينار بتاع طلبة الفرقة السادسة في وحدة الدكتور عمرو المليجي. الطلبة المشاركين الدكتورة أسماء محمد، الدكتور إسلام محمد، الدكتورة إكرام عزازي، الدكتور آية علي، والدكتور إيهاب إبراهيم. فهم محضرين السيمينار ده عن الابروتش to a patient with generalized edema. فالدكتور إيهاب هو اللي هيبتدي، فإحنا معاه. اتفضل يا دكتور إيهاب.
ماشي، أنا إيهاب وهنتكلم النهاردة إن شاء الله عن ال Generalized Edema. هنبدأ إن شاء الله ب definition. Definition of the edema هو accumulation of the excess fluid in the interstitial space or serous cavities. ماشي. بعد كده يعني نتكلم عن ال causes of generalized edema. أول سبب هو الكاردياك ديزيز، وده بيبقى بسبب الانكريز في الكابيلاري بيرميابيليتي أو انكريز في البلازما فوليوم اللي هو الهيدروستاتيك بريشر. تاني سبب اللي هو الهيباتيك ديزيز، وده بيبقى بسبب الانكريز في الكابيلاري بيرميابيليتي أو ديكريز في البلازما أونكوتيك بريشر. تالت سبب اللي هو النيوتريشن، وده بيبقى بسبب reduce في البروتين tenses leading to decrease plasma oncotic pressure. ثالث سبب هو البريجنسي، وده بسبب الانكريز في البلازما فوليوم اللي هو الهيدروستاتيك بريشر. السبب اللي بعد كده الرينال ديزيز، وده بسبب انكريز في البلازما فوليوم برضو وديكريز في البلازما اونكوتيك بريشر. واخر سبب هو الانجيوديما، ده بسبب انكريز الكابيلاري بريمبيابيلتي. ماشي. بعد كده هنتكلم عن الفاكتور اللي بتعمل إديمة. هو أول سبب انكريز الهيدروستاتيك بريشر، تاني سبب decrease في البلد فيسل انكوتيك بريشر، تالت سبب increase tissue oncotic pressure، السبب اللي بعد كده increase في الفيسل وول permeability، وبعد كده ال obstructed lymphatic drainage، وبعد كده الصوديوم and water retention. دلوقتي هنتكلم عن النورمال فلويد موفمنت في الكابيلاري. عشان نفهم الميكانيزم اوف إديمة لازم نعرف النورمال الأول. الأول الفلويد بيتحرك في الكابيلاري من الارتريول للكابيلاري. فالهيدروستاتيك بريشر في الكابيلاري بيد من ناحية الارتريولز بتبقى تقريبا 35 ملم ميركوري، اللي هي أكتر من الأوزموتيك بريشر. فده هيؤدي إلى أن الفلويد بيتحرك من الكابيلاري للانترستيشال فلويد. وبعد كده كل ما البلاد يتحرك من الارتريول لناحيه الفينس الهيدروستاتيك بريشر بيقل لحد ما يوصل في نهايه الفينيول ل 20 ملي ميركوري، اللي هو اقل من الاوزموتيك بريشر اللي هو 25. فيبدا يحصل ري ابزوربشن للفلويد الثاني. ف 85% بس هم اللي بيحصل لهم ري ابزوربشن للبين، وال 15% الباقيين بيحصل لهم ري ابزوربشن من الليمف. فأي أي غلط في السيستم ده أو في الفسيولوجي ده هيؤدي إلى الإديمة. ماشي. بعد كده هنتكلم عن الهيدروستاتيك بريشر. هو الهيدروستاتيك بريشر بيعتمد على البلد فوليوم. في أي زيادة في البلد فوليوم هيؤدي إلى زيادة الهيدروستاتيك بريشر. فالفلويد هيتحرك من الكابيلاري للانترستيشال سبيس. وهنا اللي بيعمل الانكريس في الهيدروستاتيك بريشر يا اما كاردياك كوز يا اما رينال فيلير او فينس اوبستراكشن زي في البريجنسي. تاني حاجه الانكوتيك بريشر، ده بيعتمد على البلازما بروتين. في اي لو حصل البروتين قل الانكوتيك بريشر هيقل في الكابيلاري، وده ممكن يعمله الليفر فيلير لان هو مكان تصنيع البروتين او مال نيوتريشن. تالت حاجة وهي الانكريز الكابيلاري بيرمبيابيليتي بسبب السيتوكاينز اللي بتطلع في الانفلاماتوري، فيحصل كونتراكشن في الاندوثيليال سيل فتزود البرمبيابيليتي بتاعت الكابيلاري، فالفلويد يتحرك من الكابيلاري للانترستيشال سبيس. وفي الحاجة الرابعة وهو الابستراكشن بتاع الليمفاتيك، لأن كنا بنقول إن في 15% بيحصل لهم absorption في الليمفاتيك، فلو مثلا في فلاريزيس أو أي حاجة سد الليمفاتكس هتعمل إديمة. بعد كده الميكانيزم بتاع الصوديوم اند ووتر ريتنشن، إنه لو حصل هايبوفوليميا أو هايبونستريميا ده هيعمل ستيميوليت للجلوميرولز في الكدني اللي هي هتصنع الرينال، اللي هو بيحول الانجيوتنسين لانجيوتنسين 1. انجيوتنسين 1 بيتحول لانجيوتنسين 2 عن طريق الانجيوتنسين كونفرتنج انزيم، والانجيوتنسين 2 بيروح للادرينال كورتكس عشان تطلع الدوستيرون، فالالدوستيرون بيعمل صوديوم اند ووتر ريتنشن اللي هو هيعمل إديمة. ماشي، دلوقتي كده هنتكلم عن الهارت كوز.
دلوقتي الهارت failure one of the most common cause of the peripheral edema. It is the clinical syndrome in which the heart cannot pump an adequate cardiac output at normal filling pressures to meet an adequate or metabolic need of the body. There is right side heart failure and left side heart failure, or both biventricular failure that's called a congestive heart failure. The commonest cause of the heart failure is ischemic heart disease and systemic hypertension and valvular disease and cardiomyopathy. The cardiac reserve is a compensatory mechanism, reflex tachycardia due to increase the sympathetic activities and ventricular dilatations by increase the volume load, which is lead to increase the length of cardiac muscles fiber and increase the contraction. Ventricular hypertrophy, which is increase the pressures load and increase the thickness of cardiac muscles and increase the contractions, and by the time the cardiac muscles become bigger. Redistribution of the blood volume from the skin to brain and heart. Activations of the renal angiotensin aldosterone system. In these conditions, there is low cardiac output and not enough blood pump to the body, which is lead to hypovolemia. And these conditions is stimulate the kidney to increase the renal and activate the angiotensin 2 and aldosterone, which is lead to sodium and water retentions and hypovolemia. Releasing of nitritic peptide A nitritic peptide and B nitritic peptide by stretching the cardiac muscles fiber, which is release of the nitritic peptide, which is lead to vasodilatations and increase the urinary sodium excretions. Next. The heart failure decrease in inadequate cardiac output that provided with adequate tissues oxygenations or nutritions, most often that inadequate output due to the left ventricular failure. Left ventricular failure that presented with weakness, fatigue, cyanosis, and shortening of the breath, ventricular remodeling, and cardiomegaly. The heart enlarged, it's dilated and worker harder, and the muscles get bigger. Right ventricular failure is the most often due to pulmonary disease. Okay, next. There is left side heart failure manifestations and right side heart failure manifestations. The left side is become with manifested with low cardiac output, CNS as syncope and dyspnea or headache, cardiac ischemic heart disease, kidney oliguria, and skin cold and peripheral cyanosis, skin fatigue and intermittent claudications, blood pressures, low systolic blood pressures, and the pulse is weak. Okay, the most important is manifestations of pulmonary congestions as dyspnea and paroxysmal nocturnal dyspnea, exertional cough and recurrent chest infection, hemoptysis, and bilateral basal crepitations. Okay, next. The right side heart failure as the manifestations of the low cardiac output. Additional is manifestations of systemic congestions as insomnia and sweating on slightly activity and congested neck vein, edema in the lower limb, later on ascites, liver enlarged, soft tender, and GIT malabsorptions and lead to cardiac cachexia and pleural effusions. Okay, next. The diagnosis of the heart failure, the key of investigations is echo, okay, and ECG, X-ray, cardiac catheters, and other imaging, nuclear cardiography, CT, and MRI. Laboratory, it's very important as the CBC to detect anemia, which is one of the precipitating factors, and liver functions test to kidney functions test may be impaired due to liver congestions or from the low cardiac output and renal congestions. Cardiac enzymes is very important to detect myocardial infarctions. Electrolytes may be impaired by drug intake, and PNP, which is good negative. Next. Treatment, it's depending on arrest, on medical treatment, by the way. But before medical treatment, rest, semi-sitting positions rather than lying down to decrease the venous return, diet, salt and water restrictions, sedations, and lifestyle change by mild exercise, treatment of the cause and precipitations factors as hypertension, hyperlipidemia, and anemia. Medical treatment, I will talk about it in detail in the next slide. Sometime device therapy, implantable cardiovert defibrillator, cardiac resynchronization therapy, and mechanical circulatory support, sometime cardiac transplantation. Next, the medical treatment, it's aimed on decreasing the preload by using diuretics and venodilator as nitrate, and decreasing of afterload as arterial vasodilatation, hydralazine, and sodium nitroprusside, increase in myocardial contractions as digitalis and dobutamine, and neurohormonal treatment, angiotensin converting enzymes inhibitors, and beta blocker, and other aminophylline, anticoagulant, and oxygen therapy.
بنشكر الدكتورة آية اللي هي ما عرفتش نفسها في الأول يعني. شكرا.
أنا إكرام. أنا إكرام. My name is Ekram Azzazy, and now we're going to discuss the renal causes of generalized edema. To begin with, we have to suspect that the causes behind the generalized edema is renal. The things that could lead us to thinking that the cause of the generalized edema is renal. Things are like other symptoms of renal diseases, like the pattern of the behavior of the edema itself, as renal edema usually starts in the eye, not in the legs, unlike heart failure that usually starts bilateral lower limb edema. Renal diseases most often start by buffness of the eyelids, and as a generalized edema, not with legs first and then ascends. It usually starts all together and starting with the face. Also, other symptoms of renal diseases, like if it was caused by something chronic, the patient might have an earthy look and might have previously complained of renal diseases. And obviously some laboratory and investigations could further lead us to believing The cause of this generalized edema is renal. Renal diseases can cause edema by many ways, and the most common one of them is nephrotic syndrome. And it could also happen in acute kidney injury and in chronic kidney disease. How does the kidney through any of the previously mentioned diseases cause this edema? It happens through a glomerular disease occurs, and so the glomerulus has glomerulitis. We have glomerulitis, which causes heavy proteinuria. Heavy proteinuria causes hypoalbuminemia. Hypoalbuminemia causes arterial underfilling due to the decreased oncotic pressure, and as a result, hemodynamics are altered because the water balance moves from intracellular to interstitial, which further stimulates the renin-angiotensin-aldosterone system. So it releases vasopressin and causes further sodium and water retention. And other this way, the renal diseases cause edema in several ways. It causes edema primarily by reducing the oncotic pressure through the proteinuria it causes, and it also causes the edema through the activation of renin-angiotensin system that causes sodium and water retention. And the sodium and water retention themselves expand extracellular fluid volume, which also causes edema. So this is why renal edema is usually violent or very visible and very noticeable, especially if it was in the nephrotic syndrome, like we were going to discuss in the next slide. So nephrotic syndrome is a clinical state in which there is a combination of four main features. There is massive proteinuria. The proteinuria is measured accordingly to the surface area of the body, around more than 3.5 grams per day per 1.73 meters squared surface area of the body, because we calculate it differently from children and adults. Nephrotic syndrome is more common in children, but also occurs in adults. But this is why it's important to know the different measurements and different criteria for between adults and children. The second feature of nephrotic syndrome is hypoalbuminemia. The third feature is obviously the edema itself. The fourth feature is the associations that come with the edema, like hyperlipidemia, hypokalemia, and hypocalcemia. What happens is when in nephrotic syndrome, the patient loses albumin, uses protein in general, and hypoalbuminemia occurs. The liver tries to compensate this loss of albumin, but along with trying to compensate the protein, it produces cholesterol, which causes the hyperlipidemia. Nephrotic syndrome generally the patient will complain of tiredness, a very bad state of tiredness, shortness of breath because of the edema, tachycardia, possibly vomiting, and the skin is pale, bad general state in general. It could be caused by some things that could lead us to believe that something happened and then caused the nephrotic syndrome, which is the case in the secondary type of nephrotic syndrome. But nephrotic syndrome could also be primary. It could be secondary to systemic diseases like diabetes or amyloidosis. It could be caused post-infectious, like bacterial, like post-streptococcal glomerulonephritis, or viral, like hepatitis B and C. It could be secondary to allergy, like antitoxins, or hereditary in many syndromes, like Alport syndrome. It could be caused by drugs, and it could be other causes like pregnancy or transplantation rejection. By taking some history, we might reach. لا احنا لسه معلش. I'm sorry, we're still in the same slide. Primary nephrotic syndrome occurs due to changes in the structure of the glomeruli, whether it being minimal change disease, focal glomerular sclerosis, or mesangial proliferative or membranous glomerulonephritis. In children, minimal change disease is the most common. In adults, membranous glomerulonephritis is more common. clinical features will be suggestive of nephrotic syndrome by investigations. Yes, in investigations, we have the laboratory investigations. Obviously, the albumin levels will be very low, which is the main characteristic feature of nephrotic syndrome. By examining urine, it will be frothy, white-colored froth due to the decreased surface tension that is caused by the albumin excretion or the bradykinin excretion. So it will be, there will be visible proteinuria. In nephrotic syndrome, we will also do ultrasound, but the ultrasound will not necessarily show severe changes unless it's recurrent, because in some cases nephrotic syndrome is recurrent. It could also show, investigations could also show signs of the cause of the nephrotic syndrome, like an increased azotet or ANA if it was immunological. Most commonly, primary nephrotic syndrome is believed to be due to an immunological reason. So if it was an autoimmune reason, maybe the ANA levels or the anti-double-stranded DNA could be elevated. Blood sugar could be elevated if it was diabetic nephropathy. Plasma and urine protein electrophoresis could also be helpful. Serum immunoglobulins, immunoelectrophoresis for multiple myeloma and other dysproteinemias if we didn't find the reason in the first investigations. And then there is the renal biopsy. The renal biopsy is very important in nephrotic syndrome because it also shows the reason, because if it was primary, we will be able to determine if it was minimal change, mesangial proliferative focal glomerulosclerosis or membranous glomerulonephritis. And this is important because treatment is different from type to type. After coming to the diagnosis of nephrotic syndrome, usually the treatment is just conservative. We can give corticosteroids, either oral or IV, and wait for a response. If there is no response, we move to immunosuppressants. But before moving to immunosuppressants, we have to make sure that there is no primary reason to the nephrotic syndrome, because if the patient has had HCV or malignancy, immunosuppressants could possibly be deadly. So after excluding other causes of nephrotic syndrome, we give corticosteroids, IV, and then immunosuppressants. There's other causes of renal edema, though not common, not as common to cause generalized edema, but acute renal failure or acute kidney failure, or acute kidney injury can also cause generalized edema. Acute kidney injury is a clinical syndrome characterized by a rapid, days to weeks, steadily decreasing renal functions with or without oliguria. What happens in acute kidney injury that makes it distinguishable from other renal causes or other general causes of generalized edema is the fact that the patient complains of possibly anuria or very low urine output, and it's of acute onset, which is also characteristic and helps in the diagnosis. In case of suspecting acute kidney injury, the important thing is to determine the causes, whether they are pre-renal, renal, or post-renal. Post-renal causes are generally just obstruction or retention. Pre-renal are caused due to blood loss or impaired blood pumping from the heart, or sequestration of body fluid as an extensive burn or interstitial obstruction. Or severe renal arterial spasm, like in renal artery stenosis. Generally, any cause that could cause ischemia, but the most common cause of acute kidney injury is the renal, or the most important at least. The most important is the renal causes of acute kidney injury, and the most common cause of renal acute kidney injury is acute tubular necrosis, which has to be excluded first. Acute kidney injury is determined, its severity is determined by the glomerular filtrate rate, and it consists of three main clinical manifestations. depending on the phase the patient presented in. There is an oliguric phase, and there is a diuretic phase and a convalescence phase. In the oliguric phase, that lasts from few hours to weeks, the patient complains of gastrointestinal anorexia, nausea, and vomiting. From cardiovascular diseases, from cardiovascular system, the patient complains of hypertension, cardiomegaly, and pericarditis. Complains of volume overload, puffiness, bilateral limb edema, congested neck veins, and pulmonary crackles, acidosis, and hyperkalemia. This happens in the oliguric phase, and this is the phase that the patient could be complaining of generalized edema. Then there is the diuretic phase. In the early diuretic phase, the urine output increases, but it may take several days before the creatinine starts to drop, and it can cause dehydration and hypokalemia. And then the glomerular filtrate rate increases. The patient might show uremic phases in the previous phase, but in the diuretic phase, usually the uremic features disappear along with the increase of glomerular filtrate rate. I'm sorry about the noise around me. The last phase is the convalescent phase, which of course is after treatment. The patient's general health is back to normal, and the chemistry is reversed. Complete recovery of the tubular functions may take weeks to months. The management of acute kidney failure, the most important part is the diagnosis of acute kidney failure. It's very important to diagnose as early as possible, because some causes might cause permanent changes that could lead the patient to be on dialysis forever. So we have to realize the cause and try to fix it as fast as possible. And most importantly, realize when is the decision to do dialysis is. Dialysis indications are creatinine that exceeds 9 to 10 milligram per deciliter, or potassium that's more than 6 milliosmol by carb that is less than 12. More important is the rapid change in the chemistry. More than 1 milligram of creatinine per day, or potassium more than 0.8 per day برضو. Also the hypercatabolic acute renal failure. Deterioration of mental level, acidosis, pericarditis, uremic convulsions will obviously be an indication for dialysis, even if the chemistry does not reflect the same state. Once dialysis is started, it should be regular until the kidney function improves. Other than dialysis, if the patient is more stable and there is no indication for dialysis, the patient is advised to do a proper diet, and he might take drugs if there's hyperkalemia, it's treated by potassium restriction and administration of cation exchange resins. If there is hyperphosphatemia, it's treated by protein restriction and calcium carbonate, which acts as phosphate binder and supplies calcium too. Acidosis is combated by sodium bicarb, and if there's anemia and it's the cause, it has to be fixed by iron intravenous and recombinant erythropoietin in some cases. That's all about acute kidney injury. Other cause of renal cause of generalized edema is chronic renal failure. According to our department book, chronic renal failure is now called chronic renal disease, not chronic renal failure anymore, because it doesn't necessarily mean there is a complete failure of the kidneys. It's staged into 4 main stages, depending on the glomerular filtrate rate numbers. Stage 1, kidney damage with normal or increased glomerular filtrate rate, more than 90 millis per minute. Stage 2, kidney damage with mild decrease in glomerular filtrate rate between 60 and 90. Stage 3, moderate decrease of glomerular filtrate rate between 30 and 59. Stage 4 is severe decrease in glomerular filtrate rate between 15 and 29. Stage 5, kidney failure, which is glomerular filtrate rate below 15. Glomerular filtrate rate can be calculated from serum creatinine using special equations. Chronic kidney failure patients will will be complaining of symptoms that's possibly not primary appearing as renal. Like the patient could manifest with symptoms that are CNS related, like headache, insomnia, reversed sleeping rhythm, tremors, myoclonic jerks, and convulsions, and coma even. Cardiovascular symptoms like hypertension, cardiomyopathy, heart failure, and accelerated atherosclerosis. Some chest symptoms also, like pulmonary edema and pneumonia. Obviously, some GIT like anorexia and nausea and vomiting. And what's very prominent to renal diseases is the earthy look that's obvious on the patient's face, and possibly pallor, dryness, and itching. Also skeletal system like aches and easy fractures due to the hypercalcemia, and gouty arthropathy due to the hyperuricemia. The patient might also suffer from anemia due to the chronic illness, along with other renal symptoms like the ones previously mentioned. The management of chronic renal disease is to first reach an etiology for it, because by treating the etiology that primarily causes the chronic renal failure, we can reverse the situation. And if we cannot reverse the situation, we will try to maintain the remaining kidney functions as much as possible. The reversible causes that might cause chronic renal diseases are obstruction, infection, severe anemia, severe acidosis, dehydration or overhydration, hyponatremia or nephrotoxic drugs, or improper diet. We try to preserve the kidney as much as possible. Protein should be restricted in chronic renal failure. Unlike in the nephrotic syndrome, for instance, where the patient is advised to take extra protein intake in his diet, salt is restricted in most cases. Water in the early stages, around 3 liters per day are allowed, but in the late stages, it should be restricted. The best guide to the amount of water is done by daily weighing. The rule is to give the maximum amount that do not result in an increase in the body weight. Carbohydrates or fats are allowed, and calcium is allowed, but also phosphates are restricted. Vitamins are allowed, and we should monitor hypertension, especially hypertension, which is very common to be accompanying to the chronic renal diseases. Hypertension should be controlled to 130/80 or less. In a proteinuric case, to 120/75. This is the single most important thing to do. If there's anemia, it has to be corrected. Calcium carbonate or acetate should be given immediately before meals, besides phosphate binding to control the phosphorus level. Chronic metabolic acidosis is corrected if it was the cause. Symptomatic treatment then is important to avoid nephrotoxic drugs. Beware of dose adjustment, because a chronic renal disease patient has to adjust all his medications, because many medications and antibiotics are nephrotoxic. And also, it's important to realize in chronic kidney disease when to start dialysis. The rule is to start dialysis when the glomerular filtrate rate reaches 5 milli per minute or less, or there is uncontrolled symptom. Even if the glomerular filtrate rate is high, but there is uncontrolled symptoms, dialysis should be started. And that's all about the renal causes of generalized edema.
شكرا يا دكتوره اكرام. سنتي يعني ايه مقلله السلايدز قوي خالص، واحنا كنا حابين يعني يبقى سلايدز اكتر شويه. يعني انت
انا فعلا اختصرت في السلايد شويه. قلت احط صوره واتكلم انا يعني.
شكرا لحضرتك. تمام، اتفضل.
السلام عليكم. My name is Islam Arafa and I will talk about liver cirrhosis. The next slide, brother. Definition of liver cirrhosis is the severe scarring of the liver and poor liver function seen at the terminal stage of the chronic liver disease. The scarring is the most often caused by long-term exposure to toxins such as alcohols or viral infections. Next. Risk factors causing liver cirrhosis: drinking too much alcohol, being overweight. The obese patient increase your risk of the conditions that may lead to cirrhosis, such as non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. Having viral hepatitis, not everyone with chronic hepatitis will develop cirrhosis, but it's one of the all leading to cause of the liver disease. Symptoms and signs causing liver cirrhosis: fatigue, easy bleeding, bruising, loss of appetite, nausea, swelling in your legs or feet or ankles, lower limb edema, weight loss, itchy skin, yellow discoloration in the skin and eyes, jaundice, fluid accumulation in your abdomen, ascites, spider-like blood vessels on your skin, redness in the palms of the hand, especially in women, absent or loss of period, not related to menopause. In men, loss of sexual drive, breast enlargement, gynecomastia, or testicular atrophy, confusions, drowsiness, and slurred speech, hepatic encephalopathy. Stages of liver damage: healthy liver change to fatty liver, then become liver cirrhotic, liver fibrosis, then finally leading to liver cirrhosis and liver failure. Complications of liver cirrhosis: bruising due to low platelet count and poor clotting factors, bleeding due to decreased clotting protein, sensitivity to medications, kidney failure, liver cancer, insulin resistance and type 2 diabetes, hepatic encephalopathy, gallstones interfere with bile flow, can cause bile to harden to form stones, esophageal varices, or enlarged spleen, splenomegaly, edema, ascites. This diagram showing changes occurring in the liver leading finally to liver failure. Normal liver becomes androsteatosis and steatohepatitis, then fibrosis, cirrhosis, and finally hepatocellular carcinoma. Diagnosis of liver cirrhosis by history and physical examinations. Signs of physical examinations: pale skin, jaundice, yellow eyes, redness ball, hand tremors, large spleen and liver, with small testicles, excessive breast tissue in men, gynecomastia, with decreased alert. Investigations used in liver cirrhosis: complete blood count to relieve anemia, coagulation blood test to see how quickly blood clot, albumin to test for protein produced in the liver, liver function test to alpha fetoproteins. Treatment of liver cirrhosis: beta blockers and nitrate for portal hypertension, cutting the drinking if the cirrhosis is caused by alcohol, banding procedures used to control bleeding from esophageal varices, or intravenous antibiotics to treat peritonitis that can occur in the ascites, hemodialysis to purify the blood of this in kidney failure, lactulose and low protein diet to treat encephalopathy, liver transplantation is an option of last resort when other treatment is failed. شكرا.
ماشي، أنا إيهاب إبراهيم وأتكلم إن شاء الله عن الأنجيوديما. تعريف الأنجيوديما: it is swelling in the deep layer of the skin and other tissue, and it is may be associated with the urticaria. Commonly affected area is eye and lip and mouth and tongue and genitalia and the hand and the foot. ماشي، اللي بعد كده. الcauses of angioedema: the most common cause idiopathic. Second common allergy related angioedema, زي الفود allergy أو drugs allergy. في الاس inhibitor induce angioedema. non-steroidal anti-inflammatory drugs. والhereditary angioedema due to C1 inhibitor deficiency أو acquired angioedema بسبب increase في C1 inhibitor consumption زي الليمفوما. ماشي بعد كده. mechanism of allergy angioedema. The B cell stimulated by T helper to produce the IgE antibody specific to antigen. The IgE antibody bind to Fc receptors on the surface of mast cell and blood basophil. The mast cell and the basophil coated by IgE antibody are sensitized. Later exposure to the same allergen cross-link the bound IgE on sensitized cell resulting in anaphylactic degranulation, which is the immediate and exclusive release of the pharmacological active preformed mediator from storage granules and concurrent synthesis of inflammatory lipid mediator from arachidonic acid. Some of these mediators include histamine, anti-leukotrienes, and prostaglandin. The principal effect of this product are vasodilation and smooth muscle contraction, and this leads to increase capillary permeability and lead to the edema. السلايد اللي بعده. البراديكاينين mediated. الكاينينوجين بيتحول لبراديكاينين عن طريق الكلاركين انزيم. البراديكاينين بيشتغل على البي 2 ريسبتور اكتيفيشن فيعمل vasodilation and increase الفاسكولار permeability وده يؤدي الى اديمه. في الهيرديتري angioedema بسبب deficiency C1 inhibitor اللي هو بيشتغل على الكاليركين عشان يقلل تصنيع البراديكاينين. اما في الاس انهبيتور فهو اللي بيوقف الانجيوتنسين كونفرتنج انزيم بيحول البراديكاينين لانكتيف ميتابولايتس. فالاس انهبيتور يعمل انجيوإديما. ماشي بعد كده. clinical picture of angioedema. The most common symptoms swelling في الهاند أو الفوت أو around the eye أو في lips or tongue or and genitalia. urticaria, rash, CNS symptoms, headache and dizziness, intestinal symptoms, diarrhea and abdominal pain and vomiting, throat, laryngeal edema and hoarseness voice and bronchospasm, eye symptoms, conjunctivitis. In severe cause anaphylactic shock may occur and this can be life-threatening condition. بعد كده diagnosis. Diagnosis by history of drug intake or exposure to a specific allergen or physical stimulus or family history of skin rash and allergy and may be confirmed by skin prick test to confirm a link to possible allergy in which the skin is pricked with the very amount of the allergens that is suspected. ممكن blood test show elevation of total IgE with peripheral eosinophilia. Blood test to check for C1 esterase inhibitor low level of which suggests that problem is hereditary. Idiopathic edema is usually confirmed by diagnosis of exclusion. Treatment. Allergic and idiopathic treatment of allergic and idiopathic edema by avoiding triggers and antihistaminic disease drugs and steroid medicine. In severe allergic reaction may be use adrenaline or epinephrine. Treatment of drug-induced angioedema by stop drugs and an alternative treatment need to be found. Hereditary angioedema, C1 inhibitor concentrated from donor blood, which must be administered intravenous. In emergency situation where the C1 inhibitor concentrated is not available, fresh frozen plasma can be used as is an antibiotic, and it also contains C1 inhibitor. ماشي شكرا كده.
My name is Asmaa Mohammed. The last cause of generalized edema is nutritional. There are 4 causes of nutritional generalized edema. They are malabsorption syndrome, Kwashiorkor syndrome, marasmatic Kwashiorkor, and with beriberi. Next. Mechanism of nutritional edema is protein losing encephalopathy and starvation. Malabsorption, protein absorption leading to reduced protein synthesis, leading to decreased plasma oncogenic pressure. It may be independent areas of the body like in legs. There is hypoproteinemia in which albumin concentration is less than 2.5 grams per deciliter. Next. Kwashiorkor syndrome is diagnosis by clinical diagnosis, which are there is edema in the legs, muscle wasting, psychomotor changes, and there are common signs in Kwashiorkor, like hair changes, diffuse depigmentation of the skin, moon face, and anemia. It can be diagnosed laboratory by decreased serum albumin, EEG abnormalities, iron and folic deficiencies, and the last is the liver biopsy, which show fatty or fibrosis may occur in it. شكرا.
شكرا لحضراتكم يا جماعه. طبعا البرزنتيشن يعني ما شاء الله عليها جميله جدا، ويعني to the point وممتازه.